So next is Dr. Mohammed Jafar with lessons from DC.
Thank you very much, Gil. Thank you, Scott, and thanks for the organizing committee for inviting me. Well, what I learned in Washington is that people take all the credit that you deserve and put the blame on you for whatever they have done. So what I'm going to concentrate upon is to see what thing I really can control, and hopefully I can do better. I have no financial disclosures to talk about. When we are in the operating room, the last thing that any one of us wants to do is to do the wrong surgery. We cannot really control if a patient I'm operating on for cataract is or is not going to have glaucoma, if my 5-millimeter recession of the lateral rectus muscles for a 25 prism diopters of exotropia is going to hit it right or not. But there are things that I can control, and this is what I'm going to be talking about today. And this starts actually before the operating room. It starts in the clinic when I decide, should I or shouldn't I operate? Is surgery really the best approach for this patient? Is that chalazion best treated in the operating room, or should I do the warm compresses and maybe use some omega-3 supplements and the like? When I interviewed for my fellowship many years ago, I remember very much Dr. Parks asking me, I was coming from Lebanon, asking me, well, you're here to train as a pediatric ophthalmologist. When you go back, do you have safe anesthesia to operate on a 1-day-old, 1-week-old, 1-month-old, 1-year-old? And this really stuck in my mind, and he was very right, as he was in many other things. So before we put the children under anesthesia, we really have to figure out the pros and cons and the benefits and risks. If a patient needs a pre-op consultation, let's do it. If the patient has a murmur and we're really not very sure because the family history is not very pertinent and clear, it doesn't hurt to have a pre-op consultation done and not to surprise the anesthesiologist and everybody else on the day of surgery. And clearly document the indication for the surgery and what exact surgery we're going to do on paper. And this comes very much into the picture when we have a patient with a head turn. Does this lady have a right head turn, a little bit of a left head turn, or too much of a head turn? And one thing that I like to use in the office is to ask the patient after, I tried my best and I have no idea which head posture they're taking, is to bend all the way down and then ask them when they redress, sit up again to read the chart and so on. And invariably, you really get the head posture that the patient usually needs to be operated upon. And then we get to the consent form. I know many of my colleagues would prefer to have the patient sign the consent form on the day of surgery, but I really don't like to surprise my patients with things that are on the consent form for the first time when the child is being wheeled into the operating room. And I'm going to talk about two things. In blue is what the anesthesia part talks about, and it says, I understand that anesthesia or sedation can sometimes cause sore throat, tooth injury, and then it goes all the way down to brain damage, cardiac arrest, or even death. You really don't want the parents to read this for the very first time on the day of surgery. And when we look at the specific part about surgery, again, there are things that are very disturbing, but we ask our patients to read and sign. And the generic part of the consent form that we have at Children's, it says that risk and complication of surgery include but are not limited to death, paralysis, bleeding, infection, failure of the procedure, and so on. And in the specific word that we use for strabismus surgery, we talk about undercorrection, overcorrection, etc., and then we move to retinal detachment, decreased vision, and potentially loss of the eye. I really think we need to give our patients and families the opportunity to read the consent form and ask the questions, and possibly if they want to take a copy of it, let them take it and go think about it at home before they come back. And if we need to re-sign the consent form on the day of surgery because it's more than a month old, that's fine, we can re-sign a new one. Putting the patient on the operating room table also helps, and I found out that instead of using the donut, as we can see over there, that flexes the neck, using that horseshoe that is closer to us in here is really very helpful. In this patient's, the neck is always extended, and it stabilizes the patient's head very nicely. A little bit of a purr there. We have all got to accept the fact that we have to mark our patients preoperatively, even though it makes it a little bit more time-consuming to look for the surgeon and have this done. And sometimes we're asked to sign for a patient who's going to have surgery for a chalazion on one eye. But, we do it. And after I put my famous J on the patient's forehead, coming off, I'll just touch the lid with a dot, and this is tolerated very nicely by the patient, because after we drape, that initials that we have on the forehead disappears, and having a dot on the eyelid closer to the field is really always very helpful, and it takes just a fraction of a second. Proper identification. We all go through the universal protocol and timeout. We identify the patient, which side we're operating upon, assess the fire risk, review if the patient has any allergies. The anesthesiologist always asks, do you want to give antibiotics? And then we come to the fact that we have to introduce the whole team. And I'm Mohammed Jafar, ophthalmologist surgeon, and then the fellow says, Eric. And then the anesthesiologist said, and the nurse says, it's really not good. Number one, you need to know who you are working with. If you hear something with the anesthesia monitors and so on, the nurses come in and out. We have to be more vocal and do it. But it doesn't end there. We have to stay vigilant. We really have to figure out what's going on. It is the duty of the surgeon to speak out and read the consent and tell exactly what am I going today. Is it lateral rectus recession, right eye, left eye, both eyes? We need to operate on the right eye, on the correct eye. We need to do the resection or resection and transpose up or down correctly. So we really have to be vigilant. And we shouldn't go through a timeout, burnout. I myself sit facing the muscle that I'm going to operate upon. So after all the hoopla of the consent form and the timeout, when I sit on the chair and I hold the speculum, I really have to figure out where am I going to put the speculum. If I put it on the right eye, I'm going to operate on the right medial. But if I place the speculum on the left eye, I'm operating on the left lateral. And this is the first time that I can avoid a mistake in there. So again, stay vigilant. In the old days, all our examination was on one piece of paper. But now with medical records on electronics, we have 5, 7, 8 pages that we have to look for the information. So it really helps to summarize on the day we are going to operate on the patient, summarize all our findings on one piece of paper, and this is what we call the blue sheet, the surgical plan for form, that we have it stuck on an IV pole over there. It is in your handout. If you would like to use it, please go ahead, use it, edit it, do whatever you want to do with it. And let me go over it a little bit in detail. Down and to the right is the date of when this is filled. It is filled on the day I decide to operate on the patient. This is why when I made my decision and talked to the family. And up and to the left, it clearly says this form must be completed by the ophthalmologist himself. In there, you're going to summarize all your findings and your thinking of why you decided to do surgery and what surgery you're going to do. So this is how it reads. It's quite easy. It's handwritten. On top, it has the consecutive left A exotropia, the diagnosis ophthalmologically. Then if the patient has any significant medical problems, being premature, has asthma, any allergies, shellfish, ampicillin, if the patient is on any medications, what was the last surgery that the patient had, if any, and last but not least, any complications of previous surgery. This patient had already an eye muscle surgery before, had a tonsillectomy procedure with no complications, but there is family history of maternal cousin having malignant hyperthermia. So all these things are really important to have and well written, summarized on that piece of paper. And then the second part is the refraction. This patient is highly myopic. He has an A-pattern exotropia. The motility is fine, mild overaction of the superior obliques. So I put down there what surgery I'm going to do, recession of both laterals with downward transposition, but I also wanted to look at the fundus of this patient. So I write it down there also that I need to do a cycloplegic refraction and look at the fundus on the same day. In this way, I remember preoperatively to put drops in the patient's eyes and do the exam. But also in patients who are not complicated, it's important. This patient with NLD obstruction has also anisometropia. So on my discharge, talking to the parents, I remember to tell them, come back in 2-3 months, not to look for the nasolacrimal duct obstruction and success, but to really figure out if the patient does or does not have amblyopia. So it's really very helpful. I hate to admit that electronic medical records are helpful, but you can include a picture in there. And this is a patient with a right head turn. It says up there 45 degrees. And I write by, by hand which surgery I'm going to do very easily on this piece of paper. I treat the adducted eye as if it's an ET eye, so I'm going to recess the medial and resect the lateral. I treat this XT eye by recessing sorry, this is a mistake here. Sorry. Wow. Okay. By resecting the left medial and recessing the left lateral. Sorry for this mistake in here. David Coates was visiting with us in Washington, and he showed me the white erase board where they write on the operating room wall what they're going to have in this patient. This is copyrighted by David Coates and Madhuri Shilakapati, and you can order this online. It is 2 by 3 feet, and in that specific patient, you write down that you're going to strengthen or resect the right lateral. You're going to weaken, recess the right medial, resect the left medial, and recess the left lateral. Easy to do, very nice. Everybody knows what the indication is, right head turn, and the nurses can see it, the anesthesiologist can see it, you and your assistant can see it. And last but not least, at the end of the case, we really have to include in the count not only the needles and sponges, but any tubes, any corneal shields, anything like this that has been added to the operating room field. So this is what I learned from Washington, to be safe, to keep our patients safe, and to do the right thing. Thank you.